Kia ora koutou katoa, nau mai haere mai ki te manatū hauora. Welcome back to the Ministry of Health. I'm joined today by Brigadier Jim Bliss, and I'll hand over to him shortly to make some comments, and after he's spoken, we'll then open the floor for questions. I'd just like to update you today on two areas of focus for the Ministry of Health and our public health teams in Auckland, and those relate to the Grand Millennium worker who tested positive for COVID-19 on Monday night earlier this week, and that person's known as Case A, and also our work around the Grand Mercure hotel returnees. First, on the Grand Millennium, the investigation into how the cleaner at that hotel was exposed to COVID-19 is continuing. The case and their household member who was under investigation both remain in the Auckland quarantine facility. I'm pleased to report that the household member, who you may recall had that initial very weak positive test, has now returned a second negative test at day 5, reinforcing our belief that that initial weak positive result was either a false positive or an early but very fleeting mild infection that doesn't present any risk and has now passed. She is continuing to be managed, however, as a close contact, but is not classified as confirmed case. All close and casual plus contacts of Case A have returned negative initial results. The close contacts, of course, remain in isolation for 14 days and have that second test at day 12. The results of some other tests will come in over the weekend. In terms of the Grand Mercure, as you will be aware, yesterday we announced that as part of the investigation into the recent day 12 positive case there in Auckland, we're now looking at the possibility of transmission within the facility. And our contact tracing team was hard at work yesterday, contacting those 250 returnees who have subsequently left the hotel since the 10th of March and asking them to be tested and to remain isolated until that test result's received. As at 9 a.m. this morning, 193 of those 250 people had been contacted. I expect that figure is even higher now. The remaining people are being followed up this morning. If there are people out there who have left the Grand Mercure Hotel as a returnee since the 10th of March and you haven't been contacted by Public Health yet, please do get in touch through Healthline, organise a test and remain isolated until that test result's received. There was also yesterday some additional testing, mobile testing in place on site at the Grand Mercure to ensure that there are exit tests for all returnees. And I just want to stress that we don't consider there's a wider public health risk. We are just doing this as part of being very precautionary in our follow-up of the possibility of in-facility transmission. Quick update on our vaccine rollout. That continues to scale up. Over the weekend, we're expecting over 5,000 doses to be administered around the country through the Northern, Midlands, Central and Southern regions, and also by our Defence Force. By the end of today, we will have administered over 50,000 vaccinations, around 40,000 of those first doses in people and the balance second doses. So a number of our border workers are coming through and are now fully vaccinated. Vaccinations will be delivered over the weekend at a number of locations, including hotels, doctors' surgeries, hospitals and dedicated clinics. Now, a quick update at our regular reporting on numbers. There are 3 new positive cases to report in managed isolation, and our 7-day rolling average of new cases detected at the border remains at 5. Our total number of active cases today is 74, and our total number of confirmed cases is 2,123. Yesterday there were 7,117 tests, and our rolling 7-day average of tests is 4,944. Up-to-date information on testing locations is always available through HealthPoint and in Auckland specifically through the Auckland Regional Public Health website. Jim, I'll hand over to you.
Thank you, Dr. Bloomfield. Tēnā koutou katoa. As a result of the recent situation in the Grand Mercure Managed Isolation Facility in Auckland, I commissioned an investigation to determine what happened and what improvements, if any, can be made to strengthen our processes. Part of that investigation is into the managed isolation walks that occur from 4 facilities in the Auckland area. While exercise occurs on site at most of our facilities, for these 4, there is no appropriate area on site. For returnees in isolation, being able to exercise and have access to fresh air is a really important aspect to support their health and well-being whilst they are in managed isolation. Early this month, 23 people were bused to 2 managed isolation walks, which is a now known positive case participated in. On the 19th of March, there were 12 returnees on the managed isolation walk. Of these 12, 1 is our case, 2 also undertook the walk on the 21st of March. From the 19th of March, 9 were classed as casual plus contacts, and their stay was extended by 5 days. They have subsequently tested negative, displayed no symptoms, and have been released yesterday from managed isolation. On the 21st of March, there were 15 returnees on the managed isolation walk, 14 plus our case. These 14 have had their stay extended by 14 days from the date of exposure on Sunday the 21st of March, as they've been considered to be close contacts. I'd like to take this opportunity to acknowledge those 14 returnees that have had their time managed isolation extended. I know it's a disruption to their plans, and they may be feeling a little angry. We're doing what we can to make their extended stay as comfortable as we can, but I would hope that they would understand this with a due amount of caution for their safety and well-being why we've had to extend them. I do extend my sincere thanks to them for their understanding and patience. Last night, I put a 24-hour pause on the busing of returnees to managed isolation walks. This will allow the staff the opportunity to review their processes and ensure that the protocols are appropriate. We'll also be reminding staff about our need to always remain vigilant and provide clear direction to returnees about the adherence to infection, prevention and control measures. More than 4,000 people work in our 32 managed isolation and quarantine facilities across the country, and they do a fantastic job. Currently, 125,000 returnees have come through our facilities and re-entered the community safely. We are focused on identifying what occurred in this instance and fixing it. We are working with the Ministry of Health and other agencies involved to finalise the investigation. Thank you very much. We'll now be happy to take questions.
Jim, actually, I might just make 2 other comments, just adding to what Jim has said around managed isolation. I know that Professor Nick Wilson has once again raised the suggestion that we should be following the Australian process of confining people to rooms for the duration of their managed isolation. I think 2 comments there. First of all, as you would have heard from our reporting over recent weeks, we are picking up the vast majority of our infections at the day 01 testing. And as part of that protocol, all returnees remain in their rooms until the result of that testing is available. The second comment I would make is just 2 weeks ago, you will recall that in the same weekend, Australia had cases in both Brisbane and in Sydney related in Brisbane to a health worker, but who had also been in the managed isolation facility providing care, and in Sydney, a security officer. So the confinement of people to their rooms for the full duration, which is not something, it's something of course we have considered, but we don't think that that is necessary here, and we think that the risks can, and we have a good track record of managing those risks. Confining people to their rooms for 14 days does not completely eliminate any risk associated with infection inside facilities, as we've seen across the Tasman. Happy to take questions, and hopefully they're all for Brigadier Bliss.
When you said, or maybe it's for Brigadier Bliss as well, but when you said that you considered or had considered confining people in the room, when was this consideration and what was the process behind it? Was it just mooted, or was there any investigation into it?
So we're constantly looking at exactly at the arrangements in managed isolation. Most recently, we thought about this when we had the Pullman incident, where you'll recall as a temporary measure, we actually asked people to remain in their rooms after that day 12 test to help prevent any potential that they might be infected subsequent to their even a negative day 12 test. That was a temporary measure. It's now been lifted. But at that point in time, we also considered, is there an indication either for keeping people in their rooms for a longer period, for example, from day 7 or 9 onwards, or even for the duration. At this point, we think we've got the balance right.
Was there some consideration to any negative mental health impacts of confining somebody to their room for so long?
Absolutely, that is a key consideration of why we have the current arrangements. And you've heard Brigadier Bliss talk about the importance of access to fresh air, exercise, and at the same time managing the risks both to individuals and the wider community.
A question for Brigadier Bliss.
Please.
Why was Rail Kwasnick denied a temporary pass out of managed isolation to see his dead dad?
So firstly, we'd like to pass on our sympathies to all returnees who have a loved one that passes during their time in managed isolation. I know it's a very hard circumstance for them. Personally, I do the approvals, myself and Megan Main do the approvals on all of the exemptions from isolation. We have a very strict criteria from which to make this determination from, and largely is the advice from health officials about the threat or the risk to public health as to why we would do that.
Specifically though, what was the risk of someone coming from Australia and a country which is considered so low risk that we're about to be in a trans-Tasman bubble, going into isolation and then being alone with his dead dad? Where is the public health risk there?
So we have, like I said, we have a criteria that we use in relation to travel, whether or not they need to move between locations.
Exactly. So on that point, it was MB who put him in Wellington as opposed to Auckland where his emergency was. So it was MB who added points to his score.
Not quite. We have over 6,000 people returning every 2 weeks to New Zealand through our system, and we have to move them to where facilities are available at the time. So he was moved as part of a flight down to Wellington, and that is consistent with our processes for ensuring we can safely move people and that we utilise our managed isolation capacity.
But it was that decision that gave him more points, which then didn't allow him to say goodbye to his father.
So like I say, we have the point system allows us to consider whether people could be released from isolation, remembering that this is a 14-day managed isolation and we're essentially allowing people out into the community for a period of time. So that decision is based on public health recommendations from a medical officer of health, and I take those recommendations very seriously in making that decision.
So was it specifically the inter-regional travel that his application was declined?
There are a number of criteria which we use to do that risk assessment. The biggest one for me is the advice of the medical officers of health who determine what the risk to the public is, and I utilise that to make my decision.
On the people that have had to had their stay extended, will you be cancelling their MIQ fees, given the fact that they've had to stay there for longer than expected?
We haven't considered that at the moment.
Or would you think it's a good idea?
We can consider that in the fullness of time. At the moment, we're looking to manage their time in managed isolation as comfortably as we can for them.
But should it be a no-brainer, though? I mean, given the fact that it wasn't their fault that they had to stay there more, I mean, it's almost a form of a refund, for lack of a better word.
So, as I say, we haven't considered that at the moment.
What are you hoping to figure out in the next in 24 hours? That 24-hour pause that you put on the exercise.
So, like I say, I think this is the opportunity for us, and we're always reviewing our processes and reviewing how we operate, just to take a pause to allow the staff from all of our agencies to consider their protocols. Are they following them correctly? Are they appropriate? Do we need to improve anywhere in order to say, yes, we can continue to operate under our infection and prevention control policies and standards, or do we have to make a subtle change, or do we just need to reinforce with our staff what those processes are and ensure that they're briefing correctly and that they are following them themselves.
On your health risk.
Presumably it'll be that last thing, right? I mean, surely the protocol is not to put a non-COVID case on a bus with people who don't have COVID.
Yes, that's correct.
Yeah, so it's unacceptable that that happened plainly, right? Well, what's the need for an investigation?
So the investigation goes from end-to-end investigation. We're concentrating at the moment on the part that is in relation to the managed isolation walks and the use of buses. What I can tell you is the notification of the positive test result occurred whilst that returnee was on the managed isolation walk, and that returnee was on the bus coming back to the facility when that notification was made.
Are you going to review the exemptions process to let more people and reassess them, and especially given that this public health matrix was written and not been reviewed since the 29th of July last year?
So we're always reviewing our processes and the risk assessment is under review at the moment.
It is under
Yes,
you
it is.
are reviewing it, and what
Yes, it
prompted
is.
you to review it?
We continue to review our processes and the categories and the risk assessment, and the Ministry of Health and Public Health provide us with the review and sign off on what the criteria are, which allows us to make those decisions.
And why is this information not public? Like, this is nowhere on your website, so people don't know what they're up against. They don't know that if they want to go to a funeral, that's 4 points. If they just want to see a deceased loved one, that's 1 point. And so people don't know how they could have the system work in their favour.
So largely with the application system, it's not about scoring points or trying to find points. It's about, for us, gathering the evidence that allows us to make the determination. So we engage with the returnee, or if they're already on shore in the facility, there's constant engagement with them to determine what their situation is, and then to engage with the.
Why not show them this? Why not make this public?
So we haven't at the moment. I could chase up on that and see
But
how
do
we go.
do you understand why if someone in that position is trying to, grieve, they might make different decisions and make a different application on the basis of understanding of how you make your decision?
So yeah, I mean, we are sympathetic to all the situations for people. A lot of the people that are making these exemptions from from isolation have also made an emergency allocation to come home fast. Okay, so we endeavour to bring them into the country quickly through the emergency allocation system, because they have a loved one that is either close to passing or is significantly ill, and we then work with them to bring them into the country, into an isolation facility, and then as best as we can facilitate that 14 days for them.
So are you providing them simple details, like if you are not going to attend a funeral but simply see the body of your deceased relative, you were more likely to get granted compassionate release?
Not in that much detail. So, like I say, that's a conversation that occurs between our exemptions team and the returnees when they first submit their request. And as part of that is the assessment of things like, what's their point of origin, when they've come from, what transport's required, what does the medical officer of health, not only in the region where they may be located, but potentially where they may be going to, and is there any risk to the area they're going to? Because some of these people are in hospices or in hospitals or the like, and there is due consideration for the risk to public health, which is paramount in these cases.
And would you accept that you've failed in a duty of care in the case of the people in MIQ who are put on a bus with a COVID case and are now left remaining in the facilities for longer than 14 days because they were possibly received transmission? So
as I stated before, the case, positive case, was found whilst they were out on the managed walk itself, and they were returning to the facility. So once that positive case returned, was moved into isolation and then into quarantine facility.
But should they have been put on a bus with these people who are now their close contacts? Should they have been put on that bus with other people knowingly by MIQ officials without, for example, those people being told that they were being put on a bus with someone who had tested positive for COVID-19?
So they weren't put on the bus with someone who tested positive when they went on the managed isolation walk.
But the walk back.
So the investigation into what occurred for the whole period of time and system is still undergoing, both by MIQ and by the Ministry of Health.
Obviously, this is something that doesn't happen frequently, but in the future, would you expect either the person who tested positive for COVID-19 to be put on a second bus that would come and pick them up, or those other people who hadn't tested positive?
So we haven't encountered a situation like this before, and we're talking a matter of minutes here for a decision to be made. So like I say, when we do the process review, it may throw open some decision-making processes or a method that would allow us to make those decisions and inform the staff.
People that will remain there longer, have you offered to move them into a different facility?
Yes, we have. We've offered all of them if they'd like to move to a different facility, and as of today, only one has taken up that offer.
Why?
Sorry?
Why?
Some have indicated they would have liked to have moved or can be considered to move, so we made that offer for them.
But why? I mean, what's the difference between staying at the Grand Mercure and moving to a different hotel?
So from a risk point of view, there's no difference. It's a personal preference. Some have indicated they're quite happy at the Grand Mercure. They like the food, they like the room they're in. So there is a little bit of personal choice there, and we've just provided that personal choice in this instance.
And you're satisfied there's no greater risk in moving these people who've received health
No,
advice?
so they would move under the normal level 4 conditions as they've moved to the facility from the airport.
Just
So
on
people-
rooms themselves, I understand in a lot of hotels there's like a penthouse suite at the top. What's the current system with those? Like, are they still being used?
So I can't confirm if there's a penthouse in most or any of our facilities, but we're contracted a number of rooms per facility, and we utilise those rooms that are contracted by the hotel for the best of the situation at the time. So if you've got a family, for example, that maybe have 3 kids and maybe a larger suite is available as a room, and or has some special needs around medical access and the like, then we'll utilise the stock that's available.
So there's no way that people could pay more money to get a better room such as one of these?
Not now, there isn't, no.
So not now, is that?
I understand. Well, I remember that did happen once previously, and that was stopped in January.
Oh, what happened?
So in January, which has been reported in the media before, a guest applied for a room which was not part of our stock with a hotel chain to upgrade to a different room.
Are you still, do you remain confident the Grand Mercure is safe and that isn't subject to the same sort of concern that the Pullman was?
Yeah, so we have a technical advisory group that is with engineers and medical professionals and scientists that are assessing the Grand Mercure at the moment, as they did for the Pullman. And currently, their assessment and advice to us is the Grand Mercure is fit for purpose to operate and is very low risk. And that technical advisory group will facilitate the ventilation review that's upcoming, and we take the recommendations from the technical advisory group as forward as we consider the future of those facilities.
Can we ask?
To Peter Lapel, she was not let out of managed isolation to say goodbye to her dead mum because she didn't have a negative test, but she had come from Australia, which is so low risk that they don't get a day 0 test. How is that fair?
So the criteria we use to assess each of the exemption allocations as we receive them, we take into account the risk factors, and then we go to the medical officer of health for a recommendation. And in this instance, again, the medical officer of health's recommendation was that it was not of a low enough risk to grant an exemption. Because
she couldn't get the day 0 test in managed isolation, because she was so low risk, she had to wait until day 3 to be tested.
No, the medical officer of health takes all of the risk criteria into consideration and provides us with a recommendation. And I use that recommendation to make the determination that the exemption can't be approved.
And so can you spell out specifically what was, in her case, so high risk?
So I'm not going to go through individual cases and the criteria that we went through for her individual circumstance.
I mean, your staff did that for me yesterday, and you signed off on the application, so I don't understand why you can't do that. Because we're trying to get, she wants specifics. Everyone's trying to get specifics on exactly why these people aren't being allowed out when they're coming from a seemingly very low risk country, and they're going into a low risk situation to say goodbye to an already deceased loved one alone.
Yep. So, and I was like, I'll come back to the criteria that we are using, including the country of origin, what day they're on in managed isolation, whether or not they've had their day 3 test, which she had, and what stage they are through their 14-day isolation. And people who are very early in the isolation process, before 7 days, it's very unusual, or not at all, that I've seen a medical officer of health recommend an exemption to then enter the community for a period of time and then come back.
But are you working with them on the other end of the system of, so, they're coming over from Australia, are you advising them that they could perhaps get a test in Australia to isolate at home to help their chances to get over so they can say that goodbye?
So that's not part of our current process.
Will it be part of your process?
It's something we could, we're always reviewing the process. We really always are. We're looking at the ways of what can make the process more robust and how we can communicate with all of our returnees about access to emergency allocations and applying for the exemptions.
Is a woman grieving, crying through a fence at MIQ an example of the system working?
I've got to balance the exemptions and the move of individuals and the needs of individuals with this public safety of the community and the population of New Zealand. We set a very high bar for exemptions in order to ensure that public safety, and this has worked really well for us for the last year, and has safely moved 125,000 people through our isolation facility.
Are you now expecting more funeral processions to attend at MIQ?
I don't know if that's something that people would try to organise. I can't really make a comment on that.
But are you going to manage those if they do start driving past with funeral processions and people?
We would have to consider what the effect would be on not only the facility itself, but remembering that a lot of our facilities are in built-up areas, in, for example, Auckland. Is there public safety? Is there policing effects which would make that an unsafe activity in itself.
So
Why
did
are
that
you-
catch you
why
off
you-
guard?
Sorry.
Did that funeral position catch you off guard? Or?
I personally wasn't aware of it at the time.
Why are you coming at that from a perspective of why it would be unsafe as to how we could make sure that people are able to say goodbye and do that safely?
So from my perspective, individual cases are very important. We try to meet the needs of individuals. However, the public safety and the number of people that come through my queue every day, we have to balance that public safety. And so, yes,
But I was going to say to the other point, so you seem to have come from that, from the perspective of, we'll have to see how unsafe that is, rather than how can we ensure that this is safe and this can happen?
So I come back to public safety and health is our primary concern and primary responsibility for MIQ. We balance up the criteria in order to make those decisions to ensure public health and where we can to facilitate the needs of the individual.
Given the fact there are still quite a number of people coming into managed isolation testing positive on a day 0 or a day 1, are you confident about the systems in place to detect COVID in pre-departure tests in other parts of the world?
Yes, I'm happy to respond to that question again. Just the context is, and I think Brigadier Bliss has said this a number of times, our managed isolation is in place to support our elimination strategy in New Zealand, and it has served us very well. The exemptions process is a part of that, and I think, again, it has served us very well. And I just want to endorse the comments that Brigadier Bliss has made, that actually the primary purpose of managed isolation is to protect the public health of New Zealanders, and I feel that over the last year they have appreciated that greatly. In terms of your question around day 01, this is something we are looking at specifically. The proportion of those people who have got pre-departure testing from a valid certificate of that, and we've seen very few people coming through without valid evidence of pre-departure testing. It may well be that the nature of and the reliability of that testing varies around the world. We had always assumed that, and that is why, in addition to the pre-departure testing, we have added in the day 01 testing and the requirement to stay in the room until that testing is back. So in my mind, actually, those ones we wouldn't have picked up till day 3. So the fact we're picking them up on day 01 is an improvement in the system, and it means that we can get them off to quarantine. Some of those transpire to be historic cases. So they're people who don't have active infections, so they wouldn't present any risk anyway.
Are there any countries in the world that you're particularly looking into? For example, there are about 40 to 50 people that have come back from India that have tested positive on day 1. Are you confident with their pre-departure testing regime?
We're not specifically looking at any country, and we don't have information about all the different testing approaches in different countries, but we do take on face value a valid certification of the fact that someone's had a pre-departure test, and it does require quite specific information. But likewise, as has been pointed out, aside from Australia and the Pacific, everyone has a day 01 test anyway, in addition to the pre-departure
Dr.
test.
Do you have any information on?
Just quickly, sorry. A question for a colleague. On the number of vaccinators that we have, there seems to be some inconsistency. The minister has said that there were 2,200. Subsequently, I think possibly yourself, but the ministry has confirmed there's actually 1,300. What's the inconsistency there?
I think the correct figure, I understand the correct figure is around 1,300 people who have specifically done and are certified on the Pfizer-BioNTech vaccine. They've done the 2-hour online module. A number of them have already been vaccinating. I'm not sure. I think the 2,200 figure may well have been the number of additional people who, prior to the Pfizer-BioNTech vaccine module, the number of people who we had trained in generally been able to be added to our vaccinator pool. So that was not unrelated to COVID-19, and that included pharmacists and a range of other health professionals. So they're two different groups.
And why only are 400 being used at the moment to give vaccine? I mean, there's a lot of work to be done here. Why not use more of them?
That's all we've required at the moment as we scale up in each district health board. But we have a pool, as you pointed out, of around 1,300 who have already been vaccinated, already been trained. For every vaccinator, there are 2 or 3 other people required as well. So it is very much a team.
And in terms of the scaling up, how do you feel it's going? I mean, are you meeting targets or are we somewhat behind?
We are doing very well against our modelled volumes. And as I say, by the end of today, we will have delivered around 50,000 vaccinations. That is scaling up again further next week. We've got 46 sites underway at the moment. There's another 14 coming on stream next week, right around the Motu. So it's scaling up as we would have anticipated. And again, just to reiterate the point I made yesterday, high level of acceptance amongst our border workforce, over 90%, and I think this bodes well for our program.
Do you have any data on or an idea of how many people are testing positive on their pre-departure tests and then not getting on the plane to come to New Zealand?
It's hard to get that information, so we don't really have any idea, but we do have feedback from the airlines that there are people who are not actually taking the flights, and we can only infer that may well have been because they've returned a positive pre-departure test.
And the EU is putting in new stricter controls around exporting vaccines, and including, one of their parameters is they might be able to restrict exports to countries where the epidemiological situation is less serious than in Europe, which New Zealand seems to fit pretty easily. Have you received any advice, or do you have any concerns about how that might impact our vaccine rollout?
I had a message at the end of the day yesterday from our team that they were in conversation with Pfizer about whether that may affect the export of New Zealand's vaccines, Pfizer vaccines, which are coming out of Belgium. I haven't got an update on that. I might have further information later today. We haven't had any indication at all that will be a problem for New Zealand. And to date, all our drops have come on time, and as have been indicated by Pfizer, it's been very reliable.
Yeah, Dr. Bloomfield, we've got GPs in Canterbury telling us that the Canterbury region is well behind the rest of the country when it comes to the numbers of GPs getting vaccinated. Are you aware of this? Do you know what's going on there?
No, I haven't had that specifically brought to my attention, but we are very much right around the country rolling out now to our healthcare workforce, and that includes both hospital-based and community-based workforce.
Right, and with the spare doses of the vaccine intended for border workers, before they expire, are they being given to healthcare workers in Canterbury?
I couldn't say specifically, but I do know right from the start of the program that was the case. And in fact, it was a story on the first weekend because there was a different view about who should or shouldn't have been offered it amongst the healthcare workforce. So I would imagine that in Canterbury, like everywhere, at the end of the day, if they have vaccines left over, they will have a list of people that they will call up to see if they can get them in at short notice to vaccinate them.
I just want to talk about the Health Holder and who's now done research on measuring the impact of COVID deniers like LTK or other public figures on sort of immunisation rates. Has the ministry done any sort of similar research to see how much of an impact those types of people would have on immunisation rates?
We haven't specifically done research on the impact of individuals and the information they're sharing. What we have done now is we've done 3 consecutive surveys on general attitudes, segmented by ethnicity towards the vaccine. And our most recent survey has shown an increase in vaccine acceptance, and that was across all ethnicities, which is encouraging to see. And I would say that our border workforce, which I mentioned, has got this very high rate of vaccine acceptance, includes 10% Māori, about 12% Pacifica, and a good proportion who are Asian, as well as European New Zealanders. So we're seeing high rates of acceptance right across the different ethnic groups in that border workforce.
Is it fair to really provide them as a possible example of acceptance and uptake? I mean, there are people who work in an environment that they could likely be exposed to COVID. Surely they're more accepting of their vaccine because they are very well aware of the risk.
I think it's fair. I think it's reasonable because it shows what's possible if you provide good information, if you provide a good experience, and you provide easy access. And that's the challenge and opportunity for us for the wider program. And so I'm confident that if we do all of those things, and that's what we're focused on, that we will get high rates of vaccine uptake.
Dr. Bloomfield, are you going to go over the health matrix at any point and assess that it's still fit for purpose?
Yes, of course. And one of the points you made earlier on is, of course, we're about to embark. we don't know the date yet, but on a quarantine-free travel arrangement with Australia, and arguably possibly two-way with Pacific countries. And so it's a very good time for us to do that, to look at what that exemptions matrix looks like. Of course, if there's quarantine-free travel from Australia into New Zealand, then it will become moot for people who are travelling here. They will be able to travel straight through into the community.
But do you foresee perhaps that people coming from Australia with emergencies, they might be able to do quarantine-free travel before the wider populations?
That's not anticipated at this stage. It would be it would be population wide. It would be one for all. But just to reinforce what Brigadier Bliss had said, there's a lot of work that goes in when people are required or do need to travel urgently, usually because of a dying or very unwell loved one. There's a lot of work that goes into ensuring that they can get access to emergency places in MIQ, and then the teams put in a lot of work with individuals and whānau to support them to get access as quickly as possible. But at the same time, our paramount concern is protecting public health of the wider New Zealand population, and that's served us well today. Perhaps a final question.
I was just going to, there's been talk that Singapore might be a better option for Australia, and they've for a while now they've increased their quarantine stay to 21 days for people who are coming from the UK or South Africa, those with that sort of higher risk of that variant. Is that something that's being considered here?
Not at this point. At the moment, our focus is on Australia, and also with, in particular, Niue and Cooks, with whom we've already got that one-way quarantine-free travel arrangement.
In terms of increasing people's MIQ stays, that's 21 days from those countries.
Right. No, we haven't looked at that. We are confident that the 14-day period, which is the one that's gold standard, and there are some countries that have a shorter period than that. We're planning to stick with the 14 days at this point, and that's served us well today.
Dr. Bloomfield, the Māori King received the vaccination today. How important is it for Māori leaders to stand up and take this?
Oh, look, I think it's absolutely fantastic. I knew the Māori King had very early on said he was interested in supporting the program and setting an example. I'm thrilled that's happened. And we'll be looking to a range of leaders, political, community, sporting, even public service. And I think actually Brigadier Bliss has had both his vaccinations. I've still got that to look forward to. It's very important that prominent people who are trusted by different communities are setting an example here. So I'm really thrilled that that's happened today.
Yep.
Kia ora.
Do you have a date for your job?
Yeah.
Not yet. I'll be advised by my team on the best date for that. Thanks very much. Have a good weekend.
And as we've worked out, he can't be doing it himself.
Not yet.
Clinical questioning from